In this presentation, we will be discussing developing a differential diagnosis for male GU problems in the office setting. My name is Dr. Debbie Fahey, and I am a board-certified family nurse practitioner with practice expertise in emergency urgent care. I earned my DNP in 2014, and I am a professor of nursing in the Orlando, Florida area, and a visiting professor with Chamberlain. Welcome. In this lecture, we will be discussing some common male GU complaints that you will see in primary care. These disorders include prostatitis, epididymitis, and benign prostatic hyperplasia, also called benign prostatic hypertrophy or BPH. These three conditions present with very similar symptoms due to the anatomy of the male genitourinary system, so diagnosis can be tricky. The key to diagnosis is obtaining a thorough history and physical along with appropriate diagnostic testing. Let's start by taking a look at some of the overlapping symptoms or subjective findings for each disorder before we discuss them separately. Common presenting symptoms for all three conditions can include the following: fever, chills, hematuria, dysuria, foul-smelling urine, difficulty starting to urinate or emptying the bladder, dribbling, and a weak urine stream. Additional symptoms reported can include the following: low back pain, testicular or scrotal pain, abdominal pain above the pelvic bone, pain with bowel movements, pain with ejaculation, and blood in the semen. The classification of the type of prostatitis is important for both diagnostic and treatment purposes. Prostatitis can be either acute, chronic, or non-bacterial. Prostatitis accounts for about 25% of all office visits by men, and over 50% of men will experience prostatitis during their lifetime. Chronic non-bacterial prostatitis is the most common. In fact, it is 8 times more frequent than bacterial prostatitis. Acute bacterial prostatitis occurs predominantly in sexually active men between the ages of 30 and 50 years old, whereas chronic bacterial prostatitis is most common in men older than 50. Risk factors for prostatitis include age greater than 50, history of prostate calculi, history of BPH, history of a previously diagnosed UTI, recurrent UTIs related to chronic bacterial prostatitis, and medical procedures which can introduce bacteria into the prostate. Acute bacterial prostatitis has a characteristic abrupt onset and is always associated with a urinary tract infection from bacteria that originates from the ascending urethra, from reflux of urine into prostatic ducts, or directly from the rectum to the prostatic ducts. Chronic bacterial prostatitis is thought to be due to repeated cultivation of bacteria in the urinary tract from a chronically infected prostate. The pathophysiology of non-bacterial prostatitis is less clear. Although the complaints and physical exam of non-bacterial prostatitis are similar to those associated with chronic bacterial prostatitis, the urine culture will be negative in non-bacterial prostatitis, hence the name. In acute and chronic bacterial prostatitis, the most common gram-negative bacteria are E. coli, Klebsiella species, Pseudomonas, Enterobacter, Proteus species, gonorrhea, and chlamydia. The most common causative gram-positive bacteria are Streptococcus faecalis and Staphylococcus aureus. Symptoms of prostatitis can be categorized into obstructive and irritative. Obstructive symptoms include a weak stream, incomplete bladder emptying, dribbling. Irritative symptoms include urinary complaints of frequency, urgency, nocturia, dysuria, and pain and discomfort, such as low back pain, penile scrotal pain, fever, chills, malaise, or painful ejaculation. In this table, I have included the most common symptoms reported with each type of prostatitis. You will see that many overlap, and, in fact, the symptoms of chronic bacterial and non-bacterial prostatitis are the same. The physical examination should include an abdominal examination to detect a distended bladder and costovertebral angle tenderness, a genital exam, and a digital rectal examination. A digital rectal examination should be performed gently because vigorous prostatic massage can induce bacteremia and subsequently sepsis. When we look at the DRE results for the three conditions, we expect to see the following as outlined in the table below. For acute bacterial prostatitis, a warm, tense, swollen, boggy, and very tender prostate. For chronic bacterial prostatitis, normal, but may be a little boggy or focally indurated, and non-bacterial prostatitis, a normal or tender prostate. A convincing history and physical exam is typically sufficient to diagnose acute bacterial prostatitis, but the differential should include cystitis, urethritis, pyelonephritis, and epididymitis. For diagnostic testing, we'll start with a urinalysis, and it will show pyuria will be present in all three conditions. Midstream urine culture and sensitivity, which will be negative in non-bacterial prostatitis, a CBC, leukocytosis, and left shift may be seen with acute bacterial prostatitis, a urethral swab for GC and CT, in men under 35 who are sexually active or men greater than 30 who engage in high-risk sexual behavior. Microscopic examination on any discharge secreted during the exam. Express prostatic excretion, called EPS, can be done. Description is explained in your text in Chapter 13, but it is not necessary because studies have shown that prescribing patterns for providers are about the same between those who perform and those who do not perform the examination. Feces from gloves should be tested for occult blood. Blood cultures, if bacteremia is suspected, and this would include a fever of 101.1 degree Fahrenheit. Urodynamic tests. 2, if patient complains of bladder emptying. Imaging studies are usually unnecessary, but may be helpful if the diagnosis is not clear, or if the patient is not responding to antibiotics. More advanced testing would include cystoscopy, a transrectal ultrasonography with or without needle biopsy, and a CT or an MRI. Patients who are extremely ill or with signs of urosepsis should be treated with IV antibiotics in the hospital setting. However, most men can be treated in the outpatient setting. Initial empiric antibiotic therapy should be based on the suspected mode of infection and the presumed infecting organism. Antibiotics should be adjusted on culture and sensitivity results when available. Antibiotics for acute bacterial prostatitis follow current CDC guidelines as recommended, which include a 14 to 28 day regimen of one of the following fluoroquinolone antibiotics: ciprofloxacin 500 milligrams every 12 hours, levofloxacin 500 milligrams daily, ofloxacin 400 milligrams every 12 hours, and norfloxacin 400 milligrams every 12 hours. Alternatives to a fluoroquinolone include doxycycline 100 mg every 12 hours and Bacterial double strength 1 tab every 12 hours. For STD coverage for acute bacterial prostatitis, fluoroquinolone antibiotics are no longer recommended for the treatment of gonococcal infections in the United States due to high antibiotic resistance rates. Co-treatment of chlamydia is essential because the two often coexist. Treatment includes a single dose IM ceftriaxone 250 mg plus a single dose of oral azithromycin 1 gram or doxycycline 100 mg BID for 7 days. Supportive measures for acute bacterial prostatitis include antipyretics, NSAIDs, hydration, stool softeners as needed. Urinary analgesics such as phenazopyridine and Flavox are also used. Urology referral to ensure eradication and to prevent relapse. The treatment for chronic bacterial prostatitis includes a 6 to 12 week course of antibiotic regimen, which is recommended for this type of prostatitis. The same drugs and doses as acute bacterial prostatitis are used, just the duration of the treatment is longer. Supportive measures include NSAIDs, hydration, stool softeners as needed, along with alpha-blocking agents to relax the smooth muscles around the prostate. Non-bacterial prostatitis treatment. Because the etiology for non-bacterial prostatitis is not fully understood, treatment is more complex and the patient should be referred to a urologist. If evidence of inflammation is present, a trial of antibiotics is often administered. Prostate massage is performed and the patient will be instructed to ejaculate every 2 to 3 days. Alpha blockers and other non-medicinal supportive treatment measures may also be helpful. Let's switch gears and focus now on epididymitis. Epididymitis can affect males of any age and is inflammation of the epididymitis at the back of the testicle that stores and carries sperm. There is a predisposition to epididymitis for patients with a history of unprotected intercourse, a new sexual partner, history of UTI, or urinary discharge. Symptoms can also occur following heavy lifting and/or straining, trauma, medical procedures that affect the urinary tract, and an uncircumcised penis. Causes of epididymitis in males younger than 35 years are usually due to sexually transmitted infections such as gonorrhea and chlamydia. Chlamydia is responsible for approximately 2/3 of acute cases, followed by gonorrhea and E. coli. In non-sexually active males and men over the age of 35, causes of epididymitis is most commonly due to E. coli and sometimes Pseudomonas and Staphylococcus aureus. It is also associated with distal urinary tract obstruction or any cause that can cause bacteria to spread from the infected site to the epididymitis, such as prostatitis and surgical procedures. The major complaint in patients with epididymitis is unilateral scrotal pain that often radiates along the spermatic cord or to the flank area. Pain may be experienced in the tip of the penis, and typical symptoms of UTI are present, such as dysuria, cloudy urine, hematuria, etc. With severe infections, fever and chills can occur. The physical examination should include an abdominal examination to detect a distended bladder and costovertebral angle tenderness, a genital exam, and a digital rectal examination. Scrotal swelling will be present and the testis may be indistinguishable from the epididymitis. Enlarged lymph nodes in the groin or a lump on the testis may be palpated. Rectal exam will reveal a tender prostate, but the hallmark characteristic is relief of discomfort with elevation of the testis and epididymitis. It is important to discern epididymitis from testicular torsion by checking for the friend sign during examination. By elevating the affected hemiscrotum, the pain of epididymitis will be relieved but would exacerbate the pain of torsion. The CDC guidelines for the treatment of epididymitis essentially recommend the same antibiotics that treat for GC and CT. Again, fluoroquinolone antibiotics are no longer recommended for the treatment of gonococcal infections in the U.S. due to high antibiotic resistance rates. Co-treatment of chlamydia is essential since the two often coexist. Treatment includes a single dose of ceftriaxone 250 milligrams IM and a single dose oral azithromycin 1 gram or doxycycline 100 milligrams BID times 7 days. If the cause is an STI, the patient's sexual partner needs to be treated and the patient should avoid sexual contact until the treatment is finished. Supportive treatments include pain medication. NSAIDs are effective in reducing swelling, pain, and fever. Rest, scrotal support with an athletic strap, ice packs, and the avoidance of lifting heavy objects are additional treatment options. In severe cases, a spermatic block with local anesthetics may be necessary. Finally, let's move on to discussing BPH. The prostate gland is a walnut-sized gland positioned at the base of the bladder and in front of the rectum that begins to enlarge as a man ages. It surrounds the urethra, and as the prostate gets larger, it can squeeze or partly cause obstruction. BPH is the common name for nodular hyperplasia and is one of the most common conditions affecting men greater than 40 years of age. As many as 50% of men experience symptoms of enlarged prostate by age 60, and 90% of men will report symptoms by age 85. The causes of BPH are not fully understood. Aging is a risk factor, and genetic predisposition may play a role. Androgens are thought to play a key role. There has been no concrete evidence that diet, environment, or sexual practices increase the risk for developing BPH. Obesity, though, does increase the risk of development. Symptoms of BPH usually involve a combination of obstructive and irritated voiding complaints. BPH is not life-threatening, but it is life-altering. It is important to note that symptoms are not specific to BPH, since many conditions result in an overlap of symptoms, so a complete workup needs to be completed. Obstructive symptoms include a decreased urine stream, hesitancy, post-void dribbling, a sensation of incomplete bladder entering, and overflow incontinence, along with the inability to voluntarily stop the urine stream, urinary retention, and straining. Irritative symptoms include nocturia, urinary frequency, urinary urgency, dysuria, and urge incontinence. DRE is done to determine the size of the prostate gland. The prostate in BPH is usually smooth and enlarged. If the prostate is nodular or unusually firm, cancer should be suspected. Also, the size of the prostate does not correlate with the severity of symptoms. The differential diagnosis for BPH is extensive, but the diagnoses can be categorized into one of the three following types: bladder outlet obstruction, which would include cancer, stricture, bladder, and neck contracture; non-obstructive etiologies, such as a neurogenic bladder, diabetes mellitus, Parkinson's, and medications. Irritative symptoms could be the result of a neoplasm, bladder cancer, prostatitis, or urinary tract infection. Diagnostic testing includes a urinalysis and urine culture and sensitivity to exclude infection and hematuria. A PSA is done to assess for prostate cancer. Urine cytology is done to exclude bladder cancer. The AUA no longer recommends a serum creatinine on the initial evaluation, should be done on subsequent visits or if obstructive uropathy is present. Keep in mind that there may be an elevation in the PSA in BPH, just as it occurs in cancer, so the PSA is not diagnostic of either. More advanced diagnostics include and should be done by a urologist: urodynamic studies to identify difficulties in emptying the bladder, post-void residual urine tests, otherwise known as PRV, and a cystoscopy. A patient with mild to moderate symptoms and minimal PVR may only require monitoring as long as more serious conditions have been ruled out. Avoidance of caffeine and alcohol, both known to be bladder irritants, should be recommended. Once prostatic cancer has been ruled out, medications may be tried to treat BPH symptoms. This approach is typically taken when there is not a strong indication for surgical resection or if the patient is not a good surgical candidate. Medication therapy typically includes alpha-1A blockers, which smooth the smooth muscle around the bladder neck, and 5-alpha reductase inhibitors, which block the conversion of testosterone to DHT. And these, the main ones are shown on this slide. Surgery may be indicated as well when there is urinary retention or when other symptoms are unmanageable, in which case a transurethral resection of the prostate, known as the TURP, is performed.